Good evening. As every Wednesday, we are meeting for a special academic session. I'm going to introduce the agenda, but first I'm going to give the floor to our president, Dr. Oscar Hernandez Zamudio. You have the floor, Doctor. Good afternoon. Thank you, Carlos. First and foremost, I'd like to tell you that this is a special session about primary immune thrombocytopenia. I'm very pleased to introduce Dr. Mónica Lozano-Garcidueñas, Dr. Drew Provan, and Dr. Gregorio Campos-Cabrera. I thank you very much for accepting this invitation. I thank you for your time, and I hope this session is beneficial for all our members. And I send you my regards, all the members of the Mexican group for the study of hematology. And especially, I'd like to thank all my colleagues who are attending from Latin America. I hope you participate in our Q&A session, and it will be a benefit for you. Thank you very much. We are going to listen to Dr. Martinez. He's going to introduce our speakers. Thank you very much. This is a special academic session. As in previous months during this pandemic, we've used these online sessions. We have these weekly sessions. We will have several ones. During this first special session, we are going to talk about a special issue in clinical practice, not only for hematologists, but I think indeed this is related to other medical specializations. So as every week and every time, I thank the support for organizing these activities, Dr. Oscar Hernandez Zamudio, our president, our board. Of course, this is our group. I also acknowledge the colleges of hematology. At the end of the day, they form this Mexican group for the study of hematology as a country. And of course, it is important to emphasize our gratitude to our physicians, residents, those who have graduated from hematology schools in Mexico. And I know there are also hematologists from other places. This is at the country level, of course. And we also think, and we will also emphasize this Latin American Organization of Hematology. With the participation we've had of different countries, especially in Latin America. I've told you in the previous sessions that we've had professionals from around the world. So it's very important for us. This is like a brotherhood. With many of the countries who attend these sessions every week during the different sessions. So I thank you again for this. Well, today's session is a special session for February about primary immune thrombocytopenic purpura. It was known as purpura before. So we think this is a limited concept and for us it is an honor to have Dr. Drew Provan. He is in London, UK, and maybe you know his last name because of all of us who work in hematology. He has participated in several guidelines original papers about ITP, so it is an honor to have an expert with us. And we also thank him because he is in a different time zone. There's a difference of 6 hours. We thank you for sharing your knowledge. As well, Dr. Lozano-Garcidueñas, who will talk about pediatrics, which is also very important in Hermosillo, Sonora. And now in adults, our colleague, Dr. Gregorio Campos-Cabrera, will present about this. He is from Michoacán. So to give the floor to our speakers, I'd like to speak briefly about them. As you can see in PubMed, here you can see Dr. Provan's resume. You can see all his papers that have a high impact. He is a hematologist. He is emeritus professor of the academic hematology unit of the Blizard Institute, Barts, the School of Medicine and Dentistry, Queen Mary University in London. And as I told you, he has participated in the consensus guidelines for the diagnosis and treatment of ITP, and it has been published in several journals, perhaps some of the most important ones, and he has written several peer-reviewed papers and original papers about this topic, author of several books, including Molecular Hematology, published by Blackwell Science. This is a very important textbook for us. And above all, talk about his human aspect. And he's a very kind person. Dr. Lozano, she's a hematologist pediatrician. She works in Hospital Médico de la Raza, and she graduated from the Pediatric Hematology Service of Centro Médico Nacional Siglo XXI. She has participated in several national guidelines about hemophilia, ITP, among others. She has been the co-author of several medical papers and the book Introduction to Pediatrics by Games. And finally, Dr. Gregorio Campos-Cabrera. He is an hematologist certified by the Mexican Hematology Board. He has a subspecialization in stem cell transplants. He is the academic coordinator in the School of Medical Sciences of Dr. Ignacio Chávez of the Universidad Michoacana de San Nicolás de Hidalgo. He has participated in continual medical development as assistant, speaker, and professor. He is very dynamic. He likes to share clinical cases. So we thank Dr. Gregorio Campos for accepting this invitation. Without further ado, we are going to give the floor to our guest, Dr. Provan, who will talk about the changing phase of ITP management. Thank you very much, and I'll give the floor to Dr. Drew.
Thank you. Thank you very much for that lovely introduction. It's very nice to be almost in Mexico, but not in Mexico. I've never made it to Mexico yet, but hopefully when the pandemic is over, you'll let me come and visit you. But thank you very much. It's very kind. It's an honor to speak to you today. I will try to speak slowly, but the interpreter, Anna, seems very, very good. So I'm going to talk about a few different aspects of ITP, none too deep really, but these are my disclosures. I'm going to talk a bit about how our management has changed over the last 10 years, when the old international consensus was published and the old ASH guidelines, and show how it's changed over 10 years. And then look at the newer treatments that we've been using and some new treatments to come. And then I'll just pick out highlights of the guidelines. I'm not going through the whole guidelines. I'm just going to pick out some key areas and why we changed those. And then at the end, I think it was asked that I cover ASH 2020, but I picked out 2 guidelines from ASH just that I think are interesting. So ITP has been neglected for a long time financially. There's little money for research, and there had not been great therapeutic developments until the TPOs were developed. So there are lots of unmet needs for this disease in its diagnosis and also its management. Now, the management has become much better, but diagnostically, we're still lagging behind. And for many decades, really, we just managed by using old treatments that worked in other diseases. We borrowed from other diseases because they kind of worked in ITP a bit. And because we had no specific therapies for ITP, this was really pretty much all we had. So we used those therapies, but they have side effects. And I'm not going through this list at all, but all these older treatments like steroids, immune suppression, splenectomy, they have side effects for some patients, and they have very variable efficacy rates. But this is all we had, so we had to use them. And very early on in the early 2000s, this paper was published, which is very interesting, and it showed that a lot of our patients were suffering. They were either dying or becoming ill because of the treatments we were using, largely immune suppression. They were dying from infection. They were not dying from bleeding or complications of ITP. They were bleeding from our treatment. And a lot of patients were overtreated for a long time with ITP. So we then move into a new era, which is very much driven by data, by randomized clinical trials. We had romiplostim, L-trombopag developed in the early 2000s, the TPO receptor agonists. And then I will discuss a few more drugs later on briefly. The SYK inhibitor, Phosphomacinib, the anti-neonatal FC receptor drugs, anti-complement, etc. So we're in a whole new era of therapeutics for this disease. And we're also in a new era of management for this disease. And I think looking back from the old guidelines to the new guidelines, I think what we realize really is that ITP is not really very dangerous. For many patients, it's a minor inconvenience. I do accept that some people have bad bleeding and some people may die, but that's not common in ITP. Most people are fine, but their quality of life, as I mentioned, has not been great because we have overtreated patients who do not need treatment, and we've used drugs that were never designed for ITP. And these drugs come with side effects which are, unpredictable. You don't know who will get the side effects. But we're now much more relaxed. We're not so nervous about the disease. We're using less immune suppression. We're reducing the use of corticosteroids. And I think that's very important during a pandemic, especially. We don't want to suppress the immune system too much when you've got COVID-19 around. We're trying really to maximize their life quality. So looking at the newer therapies and the new approach, Amgen, GlaxoSmithKline, of course, they developed romiplostim and L-trombopag. Novartis then bought the GSK molecule L-trombopag, and then Sobi have introduced avatrombopag. So we have 3 TPO receptor agonists, and I know these are not available in every territory of the world, but these are worldwide the 3 available TPO receptor agonists at the moment. L-trombopag, the oral once daily molecule, romiplostim, a weekly subcutaneous injection. And in the USA at the moment, they have avatrombopag, which is like L-trombopag. It's a different molecule, but it works in a very similar way, and it binds to the same site. We don't have it yet in Europe or the United Kingdom, and I guess you don't have it in Mexico yet either. So we have 3 new drugs. Big trials, we know that. They're all in the public domain, all published in Blood, British Journal, etc., published by GlaxoSmithKline, Novartis, and Amgen. The TPOs have an incredibly high efficacy rate, and they work in all patient groups: mild ITP, severe ITP, young patients, old patients, people on other immunosuppressants can take a TPO and it works, and they can stop their immune suppression. So it works in every patient, every type of patient, which is fantastic. And then we see this odd phenomenon that we never predicted, which was the sustained responses off treatment. So if a patient takes romiplostim or L-trombopag for 6 months or more and has a stable count, and they're not on a high dose, we can taper the drug or drugs, and they can remain well with a normal platelet count or a very good platelet count. And I think some of these people may be cured. I think immune tolerance in these patients who come off the therapy, I think their immune tolerance may be restored back to normal. T regulatory cells return to normal, the B regulatory cells return to normal, inflammatory molecules like interleukin-2 levels fall, anti-inflammatory molecules rise, TGF-beta levels increase. Also, TGF-beta is probably the molecule which causes the fibrosis in some patients with ITP. And then we see the FC receptors on the macrophages changing their activity from being activating to more inhibitory. So the whole immune overstimulation, the inflammatory state calms down and becomes anti-inflammatory, back to normal for many of these patients. So should we be using these drugs a bit earlier than we do? Well, these phases that we designed, newly diagnosed, persistent, chronic, these are arbitrary divisions. It's the same disease, usually from beginning to end, but we chop them into different groups to try to delay splenectomy. That's really why we made chronic ITP 12 months to avoid unnecessary splenectomies. If you use the TPA receptor agonist earlier than licensed, for example, within the first few weeks of disease or even upfront, they work much better. And the guidelines, the international consensus, the American guidelines, the German guidelines, they all advocate early use TPOs. If you look at these data from Thomas Gonzalez Lopez from Spain, on the left are the newly diagnosed patients, and on the right is chronic. And if you look at the response rate, there's a decline over time. So earlier is better, but it's off-label. Of course, it's off-label. I know that. So beyond those drugs, the TPA receptor agonists, which have transformed the care of ITP, we have the SYK inhibitor, Phosphomacinib. We have drugs undergoing clinical trial, anti-neonatal FC receptor drugs. We have anti-adult FC receptor drugs, the Bruton tyrosine kinase inhibitors and complement inhibitors. And I will just mention these very briefly. I don't want to go into huge amounts of detail. Phosphomacinib is now licensed. It's been used in America. We have it in the UK, but none of us have used it yet. It inhibits a tyrosine kinase, the spleen tyrosine kinase, and it reduces the destruction of antibody-coated platelets. And it may be useful if a patient fails a TPA receptor agonist. These are the data from the drug trial. This is Jim Bussell's paper. You can see the responders in purple and the placebo and the sort of lower line there, not really doing very much at all. So, I mean, it looks reasonable if someone fails a TPO. Now, the anti-neonatal FC receptor blockers look promising as well. And this molecule, the FcRn, it recycles antibody back into the bloodstream. So it even recycles the pathogenic antibodies back into the bloodstream, and we want to prevent that. And there are two drugs under trial. One is rozanolixizumab, with terrible names, Rozimab for short, and efgartigimod from argenx. And what these do is they prevent the recycling of antibody. So once the antibody is in the macrophage, it does not come out again, and it will clear the pathogenic antibodies. So it's like a medical plasmapheresis. It will also reduce normal antibody levels as well. This is a very quick cartoon. This is a normal macrophage. The antibodies will enter the macrophage bound to bacteria or whatever, and they recycle again, they're released again. But if you block it with the blue antibody, then the antibodies don't come out again. So the data look good. This is from rozanolixizumab, and if you look at the right, you can see the serum Ig levels, they fall on therapy, and the platelet count rises. So that's all I want to say about those. BTK inhibitors, this is another very promising drug. It's an enzyme, again, it acts on SYK, which is involved in B cell function and T cell function. And if you switch off Bruton tyrosine kinase, antibody production drops and platelet destruction drops. And there's a trial with this molecule, PRN1008, is oral, it suppresses antibody production, and more than 50% of patients in the trial, this is Dave Kuta's abstract from more than a year ago, more than 50% of patients responded, mild side effects, and it looks good. So soon we'll have TPA receptor agonists, anti-neonatal FC receptor blockers, SYK inhibitor, we'll have BTK inhibitors, and then complement, which I haven't talked about. So it's a great time for ITP. Okay, let me just do a few slides on the consensus and the ASH guidelines. We needed these guidelines. Our practice had changed. We had lots more data. We were not managing ITP the same as 10 years ago. We had to update the guidelines. And what we've done this time is we've made patients the center of the discussion. We're trying to maximize their quality of life. We're trying to avoid toxic therapies. We're just trying to move away from overtreatment, which we were doing before. ITP is benign. Most patients are fine. They either need a little bit of treatment or no treatment. And we're moving away from aggressive therapy. It's not required anymore. So 2 guidelines were published just before the ASH meeting last year. The consensus on the top, which I was involved with, and then the American on the bottom. And some people were on both guidelines. Dave Kuta, Jim Bussell, Nikki Cooper were on both guidelines. So the key themes from these 2 guidelines, ASH on the left, ICR on the right, they both limit steroid usage. They both try to delay splenectomy. They both spell out treatment goals. They both consider quality of life, and they both provide future directions. I'm going to concentrate on the consensus because that's the one I know. What's new? Well, diagnosis, nothing new. There are no new diagnostic tests. For adults, we have lots more TPO data. We have Phosphomacinib data, of course. We are saying splenectomy should only ever be carried out after a TPO receptor agonist has been used. Pregnancy, I will touch on a separate slide. Pediatrics, slightly more aggressive than before. And we have a new section called Quality of Life, which discusses just quality of life. The ASH guidelines don't have this section, but we added it because we thought it was very important. Investigation, you will see this looks like the previous version. Most patients should have the green investigations. We've added hepatitis B. That's the only new addition there. The middle column are investigations that may be useful in some patients. And on the right, they are either a waste of time or they're not widely available. For example, the platelet survival study is a good test, but it's not available in many countries. So we cannot recommend that it's required. So this looks really very similar to last time. Does a patient need a bone marrow? Well, no, they do not need a bone marrow with ITP unless they have systemic symptoms, abnormal signs, they fail initial therapy, maybe they have other cytopenias, or maybe before splenectomy, you might do a bone marrow. But in general, we do very few bone marrows in ITP now. But if you think this is not ITP, if you are worried about something that is not right, then do a marrow, of course. The goals of therapy, we tried as best we could to spell these out. Therapy, of course, should be individualized. We're trying to prevent bleeding. That's the aim, preventing bleeding. Maintaining a target count of maybe between 20 to 30,000. It can be lower. it may be higher. Of course, it's a guideline. It's not rigid, it's a guideline. Using drugs with minimal toxicity. So that goes against the old drugs, optimizing quality of life. Steroids, prednisolone or prednisone, 1 milligram per kilogram, but do not exceed 80 milligrams for 2 weeks. 2 weeks. Full dose, 2 weeks. Sorry. They either respond in green, in which case you taper and give them a 6-week course in total, or after 2 weeks there is no response, in which case you taper over a few days. So the course should be 6 weeks long, or 2 weeks, maybe 3 weeks. That should be it. No more 3 month, 4 month, 6 month courses. Or you can use dexamethasone if you wish. And we decided not to use terms like first line, second line, third line, fourth line, because we don't have the data to say what is first line, second line, third line. So we said initial treatment, which is really first line, steroids, IVIG, and then subsequent, which can be medical or surgical. Now, surgical, of course, is after a TPO. So we would prefer people use medical drugs with robust evidence, eltrombopag, romiplostim, avatrombopag, fostamatinib, rituximab, and then use the less good drugs. Splenectomy is not common nowadays, and then failing multiple therapies. Pregnancy, nothing much new. China has recombinant human TPO, but only China. We say cyclosporin A is safe to use in pregnancy, along with azathioprine, of course, and steroids and IVIG. TPO receptor agonists, we say, may be used in very exceptional circumstances. End of pregnancy, a woman in difficulty, bleeding, or high risk, you can use a TPO. There are anecdotal reports, no harm to mother and no harm to baby. Pediatrics, I will not go through in detail because I'm not a pediatric hematologist. We revised the bleeding scale, which I will leave you to read in the document. Initial therapy, nothing very new. IVIG, anti-D, steroids, really nothing majorly new there. Persistent ITP in children or chronic ITP in children, most of them can be observed. They can be rescued if need be with steroids or IVIG. TPO receptor agonists work very well. Eltrombopag, romiplostim. The licenses are for children also. They reduce bleeding. The quality of life is good. If they fail one TPO, then try the other. If they don't respond to TPOs in adolescent females, you can try rituximab. So let me just finish off this part before the abstracts. Side by side, international consensus on the left, ASH guideline on the right. Diagnosis, no change for either guideline. TPOs are our preferred subsequent treatment, and TPOs are the ASH second-line treatment. We say splenectomy after TPO receptor agonists have been used. The ASH team say splenectomy remains patient preference. We say early use of TPO, and ASH says early use of TPO. We try to limit steroid exposure, and the ASH guideline limits steroid exposure. Also, we have a slightly more aggressive approach, perhaps in children, and quality of life plays a major role in the decision making. So those are the highlights from the two guidelines. They're very aligned, they're very similar. I know there are some minor differences, but in general, they are very harmonized compared to 10 years ago. Okay, so I've just picked out two abstracts. One is from my colleague in Bristol in the United Kingdom, the flight study. Charlotte Bradbury presented this as a late-breaking abstract, which is looking at mycophenolate up front. It's a nice immune suppressant. We use it second line, third line. We have great results. She did a trial where mycophenolate with steroids is used up front, first line. 120 adults requiring treatment, one-to-one randomization, steroids versus steroids plus mycophenolate. And here's the graph. The top one is the arm which included mycophenolate, and you can see this is treatment failure. Much less treatment failure in the mycophenolate arm compared to the steroid only. What's slightly surprising, I must say, is that the red line, which is steroids only, is slightly higher than we would expect. It's quite a good rates of treatment success for just steroids. But nonetheless, mycophenolate is a great addition to steroids as a first-line therapy. And it's one of our very old drugs, but it's a good drug. It's a drug we use anyway, but it's nice to see it used in a different way. And still on immune suppression, there was an abstract here from Cricks et al. Looking at TPO receptor agonists along with immune suppression in patients who are multi-refractory. Small study, 31 patients. Most of them had splenectomy. They had either L-trombopag or romiplostim plus mycophenolate or azathioprine or cyclosporin or cyclophosphamide or something which I've never used or even heard of, everolimus. I don't know, we don't have that drug, I don't think. But immune suppression with a TPO. Now, we've all done this and we know it works, but it was nice to see some data published. The overall response is 81%, which is impressive for multi-refractory patients, and the complete response rate was 61%. Again, I think this is good. It's a difficult group of patients to treat, but nice results. So just to sum up everything I've said, we've seen big changes over the last 10 years, and I'm sure Mexico is exactly the same. We have become much more patient-focused, and we're using less immune suppression. We would use less immune suppression anyway, but in a pandemic, this is a really good move, I think. This is a new era, is very evidence-based. And the next guideline produced in 10 years' time will be very heavily evidence-based. The TPO receptor agonists introduced by Amgen and GlaxoSmithKline all those years ago have really changed the face of ITP. They've made us think about the disease. They've put the spotlight on the disease. They've caused other companies to be involved. And so for patients, it's a very good time for them compared to 10, 15 years ago. And we have other classes of drug on the horizon also. So it's a good time, if ever there was a good time, it's a good time to be a patient with ITP. So with that, I'm going to stop and I will stop sharing my screen. Thank you for your attention.
I thank you for the invitation to deliver this presentation. To share, well, I'm sharing this forum with great speakers to talk about ITP in my presentation. I'm going to talk about ITP in pediatrics. In general, we have to talk about the definition. This is an autoimmune disorder characterized by a low count of platelets as a result of the destruction and deficient platelet production. So this is the most common acquired bleeding disease. This is an isolated or a secondary primary condition, and it should be differentiated from viral infections, autoimmune diseases, especially in patients that do not have a good initial response to treatment. In this regard, the autoimmune response is triggered by viral infections, cytomegalovirus, Epstein-Barr virus, parvovirus, measles, rubella, immunizations, treatment with antivirals, and the evolution is self-limited in most of the cases. This is a heterogeneous disorder with variable clinical symptoms that go from mild bleeding to serious bleeding, which is infrequent. However, this has changed the approach, as Dr. Provan said, whether to treat or not to treat a child, to see the risk and benefit of the treatment and the side effects and the benefit, because in most of the cases, it can be a self-limited disorder. What's the impact of the treatment in pediatrics? Well, it is important to highlight in pediatrics that it depends on the age and gender. We have researched several mechanisms which say that in breastfeeding or in infants, This can be observed in boys more frequently. There are different peaks of age and differences in gender according to the age, as I've said before. And we have studied several physiopathological mechanisms. What's the impact on severe hemorrhages? In adults is 9.5%, but more in children, 20.2%. However, we are mostly afraid of intracranial hemorrhage. It's in children, it's 0.1 to 0.5%. The significant impact in quality of life is increasingly important in the management of these children, and especially apart from the bleeding symptoms or the risk of mild or severe symptoms, there's fatigue in up to 22 to 45 patients, especially when they have a relapse. So it is important regarding the impact on pediatric patients. The treatment decisions should be optimal for each patient. Despite several consensus and recommendations, they are still a challenge in most of the cases, because as pediatricians, we do not know if we should only observe the child or give intense initial treatment. So it's important to mention some differences in general regarding the presentation in adults and children. In adults, the spontaneous remission is in only 20%, and in children, it's up to 75% of the cases. The presentation in adults is insidious compared to children, which is acute, and only 4% of children have a comorbidity upon diagnosis. In adults is 30%. Something important to mention is the use of drugs for underlying diseases is less common in children, and this decreases the bleeding risk at diagnosis, which increases in adults. So, regarding the impact and the management of ITP, the diagnosis and therapies has been controversial. And with the update of guidelines and consensus, we've tried to standardize, especially terminology, to provide recommendations based on research on when and how to give or not treatment, and focused on the clinical viability of the diagnosis and therapeutical procedures. For instance, if we make an assessment or not at the beginning. And also something important is that the approach should have the least repercussion and adverse effect in the quality of life of children. Despite of side effects, I keep the treatment or I can maintain the quality of life. So this has led to the definitions and the change in the nomenclature. So the definition is a decrease to less to 100,000. And we've documented the platelet reduction. So now the nomenclature has changed, and now it's called ITP. Sometimes children are asymptomatic with minimum bleeding, and not all the patients have purpura. The fact of defining differently in acute and chronic, and now try to define it as of newly diagnosed. This is related to behavior taken with regard to the progress of treatment and the initial behavior and if there's response or not in patients. Newly diagnosed is persistent, chronic, more than 12 months. Why persistent? Because most of the children, if they don't have this spontaneous remission in the first 3 months, the rest can have this spontaneous remission up to 12 months. So the recommendation based on platelet counts are controversial, and this heterogeneous presentation in terms of hemorrhagic events is still controversial. The platelet count is not the one that dictates whether we are going to treat a patient or not, but rather the clinical condition of the patient. Children without bleeding do not require treatment, and children with bleeding and/or risk factors need treatment for a quick platelet increase in order to avoid unnecessary treatments that are potentially toxic for the patient. We do not talk about persistent or chronic ITP. In each one of the definitions, the objective of the treatment is to prevent clinically relevant hemorrhages rather than correcting a platelet count. This is included in the consensus of 09 and 11, and it's also in the update of ASH and the international consensus. The fact of having the physiopathological aspect of the disease gives rise to establishing new treatments, especially in persistent and chronic ITP. So the autoantibodies against platelet glycoproteins are still the main feature of the pathophysiology. The serum levels of thrombocytopenia are decreased. So it is important to know physiopathology. I will not go into details. We need to have more treatment options targeted to this disease. Something important in pediatrics is the diagnosis evaluation. So we should see if there's petechia, cutaneous hemorrhage. We have more severe bleeding, and the lesion is bigger in size, or the ecchymosis, which is larger. Why do I talk about this? Because this clinical evaluation criteria will be very important in children to decide the treatment. Perhaps we should only observe these children according to the initial evaluation. So it's important to bear in mind the cutaneous clinical symptoms. If he has active bleeding, epistaxis, this could be risky situations where there should be an intervention. Apart from the clinical symptoms, we have to see if there are hemorrhagic risk factors like hematuria, previous polytraumatism, and also if there's an underlying disease. Regarding the diagnostic classification, less than 3 months of evolution, it's a newly diagnosed ITP, and persistent ITP is from 3 to 12 months from diagnosis. So this will determine our treatment. And also in terms of the evolution, we are going to decide if it's a primary ITP or a secondary ITP. Something very important to consider in children is that it can be wrongly diagnosed as ITP. So we also have family thrombocytopenias. They are wrongly diagnosed, and they can be diagnosed as ITP. This should be diagnosed by pediatricians. Something that might make us suspect this is a family thrombocytopenia is that during the first years of life, there's a family positive for this disease. Some characteristic features or the lack of response to first-line treatment. Something important in the beginning, apart from having the platelet count, is to observe the platelet volume to see if there's a change in platelets, of if there are macroplatelets. So in older children and in those with a slow evolution, they can be more prone to chronic diseases. And we have to rule out autoimmune diseases associated with thrombocytopenia. Perhaps there's an Evans syndrome. So we have to conduct this exclusion diagnosis to rule out other diseases to know that we are actually before an ITP. Therefore, we need a detailed clinical history and also a complete physical examination and also a blood count, this study of hemostasis. Regarding the additional examination, whether we do bone marrow, well, is in those children who have an atypical clinical presentation and also anomalies associated in the hemogram. And it's important to do this before starting steroids. This is indicated in patients that do not relapse spontaneously or do not respond to treatment, or there are studies like lymphocyte populations, and as I was telling you, other studies to rule out autoimmune diseases. General measures for management: we should avoid IM injections. It is the and we should only consider hospitalization in patients with active bleeding or patients with hemorrhagic risk factors, or in patients whose platelet count is lower than 20,000. The objectives of the ITP treatment are mainly to prevent serious hemorrhagic episodes, and the treatment should maintain an objective of platelet count between 20 and 30,000, and the treatment should have a minimum toxicity. In general, the initial treatment, well, is observation and the platelet count. If there's bleeding, we will start with steroids. We can use prednisone. Now, if we have outpatient treatment or hospitalized patients, well, it depends on the platelet count and also if there's severe bleeding. But if there's no bleeding and we have more than 20,000 platelets, it can be outpatient treatment. Our treatment options have been divided in first, second line. If we have a newly diagnosed patient, well, there's going to be a certain treatment compared to those who are chronic patients. We use corticosteroids, and we will determine the type of corticosteroid to be used. Among the first options for newly diagnosed patients, we have corticosteroids, IVIG, and anti-D. This is what the guidelines say. And for subsequent treatment, there are medical therapies with robust evidence, like TPO-RAs, And in subsequent treatment, if there's no response, there are alternatives that have not produced a high response, especially in terms of maintenance. Regarding which treatment to use, especially as second line or subsequent treatment, it is very important to bear in mind that we have recommendations and guidelines, but not all of them have been approved by all the countries. So recommendations should be made based on the resources available and also the preferences of the patient. It's important to consider that some of the medical options might require continuous treatment in the long term. Up to 1/3 of the patients can relapse in 1 year, and up to 80% can relapse in 5 years. So it's very important to evaluate the risk-benefit, especially in children, and if possible, splenectomy should be postponed for at least 1 year to allow for remission. So this is summarized in the recommendations of several guidelines that we have available. We have national guidelines and also international ones. The last version is 2019, and we have 3 guidelines from ASH. The differences are not too large, but the update of the ASH guidelines for ITP is that they prioritize the appropriate use of corticosteroids. It prioritizes to avoid hospitalizations. It prioritizes observation and recommends a short use of prednisone. Decision-making of second-line therapy, they consider TPORAs, the ASH terms, make a classification in terms of the time of presentation, and in pediatrics, in first line or the initial treatment is especially for patients that do not have severe bleeding or only mild bleeding, irrespective of the platelet count. So this is what is recommended: observation instead of corticosteroids or IVIG. Obviously, if there's a newly diagnosed patient with bleeding that does not risk his life, so the panel suggests corticosteroids rather than IVIG. Now, talking about steroids, it could be prednisone, 2 to 4 milligrams per day, maximum 120 milligrams during 5 to 7 days. And one of the options, dexamethasone, up to 40 milligrams per day for 4 days, according to the response. So it's important to know when to start or not treatment. If there's bleeding that requires hospitalization and treatment to increase the platelet levels, but it's important to bear in mind that moderate bleeding needs hospitalization. We've talked about the high risk criteria if bleeding if bleeding worsens or there are important comorbidities. So we also have to bear in mind if parents are reliable, or maybe the parents are anxious and they are unreliable. So in first line, we have prednisone, and immunoglobulin is efficient with a specific doses. It's continuous infusion between 6 and 8 hours. And we also recommend corticosteroids In the first line, we have these options if children have bleeding. Now, in terms of emergency treatment for children, platelets are contraindicated unless there's bleeding. And we can also include a combined therapy, including the transfusion of platelets, IV corticosteroids, and IVIG, with or without anti-D. So we can also use platelet transfusions followed by continuous infusion in combination with IV steroids. This is not strictly an emergency treatment. So if there's no response, especially in the first line treatment, in this case, preferably, we observe most of the patients. In this chart that was established in the 2019 consensus, ASH added to this algorithm is the use of the TPORAs. In this sense, we must decide which one to use to reduce bleeding, the duration, whether the ITP is primary or secondary. This is what we have to take into account for this second line treatment. Once the patient has been with symptoms for more than 3 months. So TPORAs are suggested before rituximab and splenectomy, and rituximab instead of splenectomy. Other treatments available are some that we have used for many decades, like azathioprine, cyclophosphamide, cyclosporine, danazol, dapsone, mycophenolate, mofetil. So here you can see the response achieved with these treatments. So these are the responses obtained with each one of these treatments. Now we are going to talk about the TPORAs and the dosing of eltrombopag. The lowest dose is for ages 1 to 5 years. And if there's a disability, we are going to reduce the dose. There are some studies like PETIT and PETIT-2 show that eltrombopag with children with chronic ITP, there was a platelet count of 50,000, at least in 80% of patients, and in PETIT-2, 40% of the patients had a platelet count of 50,000 during 6 weeks. My apologies, Dr. Provan, her microphone is not working very well. Okay, so we have also romiplastim in Mexico, and the initial doses is 1 milligram per kilogram per week, administered subcutaneously. And we can use an initial doses of 3 milligrams per kilogram per week if there's no risk of thrombosis. And there are studies of romiplastim in children with ITP. whose response rates are 71 to 88% and a mean time of response of 4 to 5 weeks. There's another study in the long term. There can be a sustained response. These are the options we have available. These are some of the adverse effects of using TPORAs. Very quickly, I'm going to explain that there was a systematic review Something important is regarding the presentation of bleeding is what's more frequent in the group with eltrombopag than placebo. Here we can see the studies and the response in terms of the increase in platelets and bleeding events. Rituximab can induce responses in children with chronic ITP. The global or the overall response rates to rituximab in this population is between 23 and 69%. The relapse rates go from 14% to 42% among those who responded within 1 year. So now rituximab is one of the first-line treatments. Splenectomy in ITP can achieve a high and lasting response. So we cannot reach firm conclusions about splenectomy in children from literature. Splenectomy is rarely indicated for children ITP. It should only be considered in children who have failed all the available therapies if they have thrombocytopenia related to bleeding and if their condition is life-threatening. So splenectomy should be avoided if possible before if they are under 5 years of age. And before considering splenectomy, we have to reevaluate the diagnosis of ITP by excluding alternative diagnoses that include hereditary thrombocytopenia. So this is time for a new approach to early management of children with ITP. Finally, I want to highlight that there are some question marks regarding ITP and COVID. So as first line, we recommend TPORAs if the patient does not have a confirmed diagnosis of COVID-19. And the treatment with the steroids should be limited because they can be risky for these patients. So in post-splenectomy patients, we have to comply with the prophylactic antibiotic therapy and the vaccination scheme. And we suggest to decrease the frequency of platelet count and avoid visits to health centers. So, in conclusion, there are several medical options for the treatment of ITP in terms of the first and second lines, including rituximab and TPORAs. TPORAs have shown convincing evidence of platelet response and decreased bleeding. And recent data indicate that TPORAs are as effective in early ITP and persistent or chronic ITP. TPORAs can induce an immune response. So the key adverse effects associated with TPORAs include thrombosis, the formation of autoantibodies, or worsening of thrombocytopenia, or an increase of reticulin in the bone marrow. So there are unmet needs in this area of the disease that require more consensus. So nowadays, TPORAs are recommended as a preferred treatment. I thank you very much for your attention. Good evening. Thank you for the invitation to participate. And I'm going to talk about primary ITP in adults. We've reviewed the guidelines, and I'm going to talk about the practice. These are my disclosures. And very quickly, well, this is an autoimmune syndrome of platelet destruction mediated by autoantibodies and with an impairment in megakaryocytopoiesis. The incidence is 2 to 10 for every 100,000 people per year, and a prevalence between 3 to 20 people for every 100,000 people. So there's an exclusion diagnosis, and the platelet count should be lower than 100 for every 10,000. So we have to rule out if it's primary or secondary ITP. There's no definite biomarker, but not all health centers perform these tests. So we are going to conduct the basic studies that have been mentioned already. Although there are additional criteria that have been suggested, that is the platelet count with nadir lower than 20,000, response with steroids or IVIG. And also in the new ASH guidelines 2019, they say that a small course of steroids can be considered in those patients who are asymptomatic and we want to corroborate they have primary ITP. So a short course with a response can be helpful. And in the case of the secondary ones, we give treatment and should increase platelet counts to more than 30,000. This picture was already presented, the pathophysiology of ITP, the antibodies, and the presentation of macrophage, the formation of more antibodies. This image is a classical one because we see the balance of T cells that do not only involve antibodies, and the tolerance is lost due to the decrease of the Tregs, and there's an activation of the immune system, mainly of pro-inflammatory cytokines. Therefore, we develop immune thrombocytopenia. And let's remember that this reduction in platelets is directly related with the decrease in Tregs and an increase of the pro-inflammatory profile type 1. Well, we know that there's a primary, acute, chronic, and persistent ITP due to the formation of autoantibodies or autoreactive antibodies. We know that the classification by evolution is acute, first 3 months, persistent between 3 and 12 months, and chronic more than 12 months. We have some guidelines already, some recommendations from the German group mainly, the ASH guidelines, and also something practical are the self-assessment programs by ASH that give us key elements to treat the disease. I'm going to go quickly over this to give more time for the Q&A session and avoid being repetitive, because some of these concepts have been mentioned by Dr. Provan. The recommendations for treatment in adults, if the count is less than 30,000 platelets and they are asymptomatic or mild bleeding, generally we have to give treatment with steroids. Consider observation in special situations like lack of bleeding, the age, if they are young, they should not be frail with no physical intense activity, they do not exercise, or they don't have risk activities like being a mason or being drivers. If they are receiving anticoagulation, and they should not have comorbidities that may risk the patient. So generally we treat with steroids. If the count is higher than 30,000 platelets and they are asymptomatic or with mild bleeding, generally we observe the patient treatment with steroids for patients who are elderly with comorbidities, diabetes, hypertension, kidney failure, etc. Patients who need anticoagulants due to an embolic disease, due to a mechanical valve, or maybe they require invasive procedures. In this case, we treat with steroids. Now, in terms of hospitalization or outpatient treatment, if this is a newly diagnosed patient, well, oftentimes we don't know how they behave. If they have bleeding, we want to know his evolution. In that case, we recommend hospitalization when they have less than 20,000 platelets. And patients might need hospitalization if they are refractory with major bleeding, and also when we need to complement the diagnosis. We've seen that generally we don't need a bone marrow, but if they did not respond to steroids, we should consider a bone marrow. But because we might be facing myelodysplasia, and also those patients who have comorbidities, especially those that require the use of anticoagulation. It is recommended to have an outpatient treatment in patients with a previous diagnosis, and we already know their behavior, and their count is lower than 20,000 platelets, and if there's no major bleeding. Those patients with a new diagnosis and a count higher than 20,000 platelets, we can consider the outpatient treatment close to the hospital where we are treating him, and they have a low risk of bleeding and with no significant comorbidities, or that they are not using anticoagulants. In that case, we prefer an outpatient treatment, and especially nowadays due to the pandemic. Once again, the guidelines, the ASH guidelines, make a recommendation in the use of steroids, short treatments less than 6 weeks, and monitor the side effects of steroids. Actually, they are emphasizing more quality of life, hypertension, mood swings, insomnia, a higher risk of infections, etc. That's why the courses less than 6 weeks is preferable. The type of steroids, it can be prednisone, 0.5 to 2 milligrams per day, or dexamethasone, 40 milligrams for 4 days. And even they still haven't reached an agreement if it's more cycles of dexamethasone. And they also mentioned to consider adding rituximab in selected patients, young patients who might be free from the disease or a high recurrence. So some selected patients, we can add rituximab to dexamethasone or to prednisone and monitor their quality of life. The ASH recommendations for second-line treatment are those refractory patients or those steroid-dependent patients. And the duration of ITP is more than 3 months. We should prefer the TPO-RAs. It can be Trombopac or Romiplastim that are available in Mexico, but also Abatrombopar is considered. And consider the use of rituximab. If you have a drug that is not approved by the FDA and Cofepris, and it is widely used in all the centers and our institutions, because here we have more access to rituximab than to TPO-RAs. Therefore, we use rituximab a lot with very good results. There are also patients who have health insurance, and rituximab is not authorized, and we have to opt for using TPO-RAs with very good results as well. So any of both. And splenectomy is preferred after 1 year. And it is said that before splenectomy, we should use the TPO-RAs and rituximab. However, it is important to individualize and adjust the treatment according to variables, the access to rituximab, the access to TPO-RAs, the costs, and splenectomy. Generally, I repeat, after 1 year, given that some percentage of patients will achieve remission after 12 months. So we should have to consider this, but after 12 months. And the third-line treatments are based on very few randomized studies with several results, but we have to assess the cost benefit, and also we can use them before second-line treatments. This is important because in our country, the azathioprine, the cyclophosphamide, nowadays cyclosporine and azathioprine and cyclosporine give very good results with a very high percentage of responses. They are cheap, they are economic, more than TPO-RAs, and they can also be used as second-line treatment. Yes, it's true. The guidelines are recommendations. Obviously, steroids, IgG can be used primarily, but as second line, even though it's true that we recommend rituximab, most of our population can't afford this, and we have to use immune suppressors. We do not have oral cyclophosphamide anymore. Cyclosporine is an option. Mycophenolate is a good option. I don't like danazol for the effects on women. Yes, it has good responses, but it has many side effects on women. And in men, benign prostatic hypertrophy, and even prostate cancer, even though we are following them up with prostate antigen. have 3 cases where patients developed prostate cancer due to the use of danazol. So personally, this is a drug that I don't like. I'd rather use a combined immunosuppression and monitor infectious processes. There are no recommendations about the doses and the time to be used, but they are very useful. And also, they can be used in combination. What are the limitations of these guidelines? Low or very low level of evidence. The comparisons are indirect. They do not include other possible clinical scenarios like major bleeding that is life-threatening, pregnancy and breastfeeding, and they do not suggest the simultaneous use of treatment that are broadly used. Here, I'd like to mention that phase 4 trials could give us relevant information. Why? Because one thing are the guidelines and the pivotal trials with selected populations. However, when we talk about real life, phase 4 trials give us the opportunity to assess and also know the options being used by doctors in their clinical practice. The simultaneous use of treatment, I repeat, is broadly used. We use immunosuppressant to save azathioprine. Rheumatologists use immunosuppressant a lot to avoid side effects, and we also use other treatments with the combination of immunosuppressant to spare us from the effects of steroids and also improve the quality of life. Even though these recommendations of 2019 are being updated, the guidelines of 2011 of blood and 2018 are still in effect, and these are adaptations, and above all, in the quality of life. Splenectomy, for me, is an optimal treatment for me. Yes, it has to be used after 1 year or more if it can be delayed. I want to explain why later on. Very quickly, Paul Kesnesson, who was the student, and Hermann Schaffler, the surgeon, made the first splenectomy in 1916 in analogy to the platelet destruction in the spleen, as it happened in the hereditary hemolytic anemias. Nowadays, it is performed in less than 25% of patients, but it can maintain complete responses of 60 to 70% at 5 years. This doesn't happen with the previously mentioned drugs, neither steroids, immunosuppressants, agonists, or other treatments. So this is important. We haven't validated the prognostic factors, but sometimes we use indium 111 labeled platelets and phagocytosis in the spleen. Now, in this follow-up at 40 years, this is very interesting for me. What is significant in patients with splenectomy was what you can see in these charts. You must remember that we have risk scales for thromboembolic disease or thromboembolic events, and we can make decisions regarding prevention before they happen. So it's 40 years. Even though the risk of thromboembolism increases, we have scales to improve or decrease the risk and act with antithrombotic prophylaxis. Look at the risk of CV events. It's not significant. The risk of infections is not significant, and overall survival in splenectomy and non-splenectomy is similar. The overall survival does not decrease. So I think splenectomy is still valid and being considered in our country. So why did we conduct many splenectomies? The first considerations in 96. So in this consensus of 96 by Dr. Josh, you can see at least 6 weeks after diagnosis and platelets lower than 10,000, at least 3 months of diagnosis and platelets lower than 30,000, both conditions with or without bleeding. This was what was recommended, but some members of the panel had different opinions. One panelist recommended splenectomy as early as 2 weeks, and another not recommending splenectomy even after 10 weeks of unsuccessful treatment. So now we have the advent of new agonists. Now we have rituximab since the 90s, and this has delayed splenectomy to more than 1 year. So I agree. It should be delayed as much as possible. But if our patient has no access to rituximab and no access to agonists, and he doesn't want steroids or combined immunosuppressant, splenectomy is still a very good option, especially due to the costs. Even though it is true we are a rich country, but mismanaged. You can see in this study that splenectomy is $20,000 per year, TPOR is $108,000 per year, and rituximab should be applied because we should know how to dissolve the molecule so that it doesn't lose its effect. The TPORAs are very, very good. The problem is that you should be fasting, and rituximab is $10,000 to $40,000 per infusion of 4 doses. Very quickly, COVID guidelines. I mean, our pandemic, acute ITP cases and recurrences that in treatment are very few. We have to suspect immune thrombocytopenia if there's a sudden decrease of platelets or a decrease of platelets of less than 50% in 22 to 48 hours. Obviously, we need differential diagnosis like microangiopathic hemolytic anemia, drug-induced thrombocytopenia, and consider ITP in stable patients who developed isolated thrombocytopenia. In SARS-CoV-2 negative patients, the first-line treatment with prednisone, dexamethasone, or methylprednisolone in serious cases, prednisone 21 doses, full doses, and then 21 days tapering until discontinuing, and dexamethasone 40 milligrams daily for 4 days. If it's SARS-CoV-2 negative, nevertheless, we don't know if patients can or not be in contact with a carrier and can be infected. And the recommendations of the WHO suggest to add TPORAs, to use steroids as least as possible, and add IVIG and transfusion of platelets in patients with active bleeding. In patients with SARS-CoV-2 positive, these guidelines recommend low doses of steroids because it has been seen in patients with influenza that the use of steroids has a higher risk of infection due to opportunist infections. In patients who are infected with MERS or the Middle East Respiratory Syndrome, and that's why minimum use of steroids is recommended, and also low doses of steroids and the use of IVIG to decrease steroids, and also consider that TPORAs can increase thrombotic coagulopathy. So if they are positive, use them cautiously, or maybe do not use them, and also avoid the use of immunosuppressant and rituximab. Those patients with persistent and chronic ITP, the treatment should not be changed except for rituximab, that should be discontinued. Patient with splenectomy without risk of infection for SARS-CoV-2, but had the risk of opportunistic infections, and those patients without treatment with immunosuppressant for more than 12 months, only general measures. And in case of relapse, treat as acute ITP. That is with the recommendations for primary acute ITP. Patients with ITP without thrombocytopenia should receive anticoagulation according to the guidelines of the Anticoagulation Forum. Patients with ITP and thrombocytopenia, prophylactic doses with platelets above 30,000 and pneumatic compression with platelets lower than 30,000. If they already developed thrombosis due to COVID and they need anticoagulation, the anticoagulation is only with platelets above 50,000, reduction with platelets between 30,000 and 50,000, and compression, pneumatic compression, platelets below 30,000, recommended by Anticoagulation Forum. But since 2013, in those patients who received anticoagulation, we already had the recommendations. Patients above 50,000 platelets, full anticoagulation above 50,000. Okay, very quickly, yesterday, these guidelines were published by ASH, the 2021 guidelines for the use of anticoagulation in patients with COVID-19. And something interesting that will be discussed in our monthly sessions is that they divide the intensity of anticoagulation in prophylaxis, intermediate, and complete anticoagulation. And they are also making recommendations on which anticoagulants can be used, not only low molecular weight heparin or vitamin K agonists, but also they are talking about oral and direct anticoagulants, apixaban, rivaroxaban, edoxaban. So this is quite interesting, and I repeat, certainly this will be a topic for us to discuss in the following months, these new guidelines for the use of anticoagulants in COVID. And just to finish, well, we have the SYK inhibitors and the FcR blockers due to the physiopathology of the disease, and also the CD40L and CD40 blockers through monoclonal antibodies or small molecules to affect lymphocytes B and the formation of antibodies. There are studies underway, and also to change the phenotype of T cells to have a more permissive and less pro-inflammatory profile. And so we have the CD40L and CD40 blockers. And also in the mesenchymal cells, where atorvastatin and the N-acetylcysteine can play an important role to immunoregulate that pro-inflammatory environment in the bone marrow. And finally, the TPORAs like amifostine and oseltamivir to induce the production of platelets, the deserialization, and also help in the maturation of those megakaryocytes with these drugs. There's a very extensive review in this paper from 2019 that talks about these drugs and how they work and explain their pathophysiology. If you want to delve into this paper is a very good one and goes in depth. Thank you very much. Now, this is the moment for our Q&A session and your comments. I want to tell you, and our guests, of course, Dr. Drew, Dr. Mónica Lozano, and Dr. Gregorio, and of course, our president, that in fact, it's great to share with you that today, and also share with our audience that today we are about to break the record of the number of attendees. We have 1,327 people attending. Through Facebook, we have 70 people. But most importantly, we have all sorts of people, and it's very rewarding for us as hematologists because we have physicians, chemists, and well, we have people from all walks of life because hematology covers many sectors, many professions. And most importantly is the fact that even though most of the people attending is from Mexico, we also have people from Bolivia, Peru, Bolivia 45, Peru 23, Ecuador 12 people, Paraguay 8, Colombia 7, Argentina, El Salvador, Guatemala, Cuba, Honduras, Chile, Costa Rica, Venezuela, Spain, Dominican Republic, US, and Nicaragua. So it's a pleasure to share this information with you. And regarding the region or the states, even though I try to invite my students and have people from Mexico City, Michoacán has the highest number of people present. I think Dr. Gregorio brought his students, his colleagues. Thank you, Gregorio. Almost 400 people connected from Michoacán. It's the first time they surpassed Mexico City, almost 150 people from Michoacán. Guanajuato, Puebla. We have people from all the states. This has piqued your interest, your curiosity, and as organizers and as a board, our duty is to organize this. So our guest is what made this very appealing, Dr. Drew. Thank you very much again for being with us. In general, there are many questions. Dr. Drew, I'd like to ask you something you emphasized a lot, and it has produced expectations. That is the first-line treatment, doctor. Recently, in ASH, the first-line treatment with steroids was mentioned with mycophenolate, and seemingly, once the analysis is made and it is published, this can be an evidence. But one question is, as first line, there are patients that do not respond. There are previous studies, probably you went over them. They use dexamethasone, low doses of rituximab. Actually, there's a colleague in Monterrey. He used as first line rituximab plus steroids, and he published another study with eltrombopag, with steroids. So even though these are studies with a few patients, I mean, rituximab, eltrombopag, apart from the use of mycophenolate plus steroids, is there another line of treatment or an additional scheme apart from mycophenolate and steroids as a first line, or only consider steroids? And if the patient does not respond, add mycophenolate. Given your experience, Dr. Drew, what are your comments in this regard?
Thank you. That's a very interesting question. First-line therapy, as you say, has not changed for many, many years. And the reason these various phases of therapy stay the same is because of lack of data. We need studies with evidence in order to make strong recommendations, first-line and subsequent therapies. So there are very few studies for initial or upfront treatments in ITP. We have lots of years of experience of using steroids, of course. The mycophenolate abstract from ASH was the first nice study looking at an immunosuppressant with steroids up front. So that gives us something that maybe we can build into the revision of either the ASH and the international consensus and the German and the other guidelines. Well, that's great. There's rituximab up front also, which as you mentioned as well. Well, if we see nice data there and it's persuasive, then of course that may then be a first-line option also, and it may change the natural history of the disease more than corticosteroids alone. And then there is a great interest from the hematology community to use a TPO receptor agonist up front. Now, the reason we don't use it up front is because it takes 7 or 10 days to see a response to eltrombopag or romiplostim or avatrombopag or lusatrombopag. So that's not great in the initial setting. We need something fast. So steroids will probably be part of first line for some time to come. They're very cheap. They don't require special storage. They can be taken by mouth and they work very quickly and they work in most patients. So that's why steroids have got such a strong influence on what we do, because of the reproducibility, the reliability of steroids. Although we know the downsides, there are lots of upsides if they're used well. But I think steroids for a very short period with maybe eltrombopag or romiplostim, and then get the steroids dose down and stopped fairly quickly, maybe a week, maybe 10 days, and then let the TPO take over, or maybe mycophenolate, or maybe in other studies it will be azathioprine. I don't know. We need data, and it will change. I think first-line therapy will change over the next year or two. I think so.
Thank you, doctor. And I'd like to ask this, especially in adults, but also in pediatrics, the current role of high doses of IG. So it can be used in patients with critical bleeding or to increase platelets, or would they be used at a different point in adults? And Dr. Monica, can you answer this for the case of children?
Is this for me? Sorry, are you asking me? Okay. Okay. IVIG is an established therapy since the 1980s. It works well. We know that. It's a pooled blood product, and it's a precious resource. And we in the United Kingdom have started to limit the use of IVIG in hematology, in neurology, and in other branches of medicine where IVIG is used, because there was a shortage, as you know, a number of years ago, and periodically we run out of IVIG. There's a shortage worldwide. So we have limited IVIG in ITP in adults. We're only allowed to use it if there is wet purpura. If the patient is bleeding, we can use it. So if someone comes with new ITP with a very low platelet count with bruising, we cannot use IVIG. If they have low platelet count and bruising and gum bleeding or nose bleeding or heavy menstrual bleeding, whatever, any form of wet purpura, we can use IVIG. 1 day, only 1 day, at 1 gram per kilogram for 1 day only. Previously, we used 1 gram per day, 1 gram per kilogram per day for 2 days, but they thought this was too much, unnecessary, so let's try 1 day. So that's where we use IVIG. We also use it occasionally in a relapse as a rescue therapy if we need to have IVIG plus steroids in an emergency. Of course, if someone comes in as a new patient into hospital, and we often give IVIG, intravenous steroids, sometimes rituximab as well, sometimes Atp as well. We throw everything into the real dire emergency. And then occasionally, not so much now, but occasionally before dentistry, if the platelet count is low, before hip replacement, or any major surgery where bleeding will take place, we sometimes use it there, but more often than not, we use a short course of dexamethasone 1 week before, or sometimes a TPO receptor agonist now. So those are the places we use it in adults. We use very little IVIG now compared to, say, 2 or 3 years ago. The usage has gone right down.
In the case of children, Dr. Lozano? Yes, doctor, in the case of children, it's shown that the efficacy is the same with IVIG and steroids. With IVIG, it is quickly increased in the first 24 hours. So steroids are used if the patient is stable, and IG if he has mucosal bleeding or bleeding that needs to, well, if they need to improve their platelet count. And the doses is 1 day, 1.8 gram per kilogram, a single doses. Thank you. Gregorio, I'm going to ask this question. Now that we are talking about emergencies with high dose IG, what about platelet transfusions? When to use it? You can tell us what guidelines say and what you do in your experience. Well, there are several questions related to transfusions. Should we conduct a platelet count? And you can also make a comment about high doses of IgG. Regarding IgG, it's true it is a limited resource and is costly. So the French group published in Hematologica in 2015 a score to assess the bleeding risk, and it gave different scores to petechia or wet purpura, and they added points and to add IgG if they have more than 7 points, and if they have more than 7 points and if there are risk of bleeding, we should add methylprednisolone. This is in a case-by-case basis. So we need to optimize the resource because it is expensive and scarce, and this score can help us. And regarding platelet transfusion, yes, do not use them alone, but if the patient has bleeding in vital organs or the central nervous system or in the lungs or in the eyes, and use it along with steroids and IgG. And personally, I start the bolus of methylprednisolone for 1 hour to avoid complications, especially heart complications, and after bolus, platelet transfusion. Well, the subsequent platelet count is variable. There can be a marginal increase. And I also focus on the clinical manifestations. But if it goes from 0 and he has 5, 10, and the bleeding manifestations with that patient who has lung bleeding, he has wet or dry purpura. That's why we have to check these patients constantly, because wet purpura is the previous step to a cerebral bleeding, and he has to be observed. If they have visual alterations, we use IgG and platelet transfusions. And something very important is to be aware of the symptoms of the patient, because, well, lab tests are very useful, but clinical manifestations, maybe he has wet purpura. Obviously, we prefer platelets from a single donor rather than multiple donors. Because of the halo sensibilization. Thank you, Gregorio. Well, I think that, well, there are several questions. This is for Dr. Provan. I think that the actual challenge we are facing, both in children and adults, are refractory cases. Patients, and it's much more common in adults, those patients who has been treated with all the drugs available nowadays, with the new options or the new clinical trials, those patients who after splenectomy do not respond, which lines, and based on the studies, can we follow in those patients who do not respond? Steroids, shall we add thrombopoietic, or do we use new agents? What could be your suggestion for refractory patients, Dr. Provan?
Thank you. Well, I think that's probably it's the most difficult question, and it's the group of patients who keep us awake at night, because ITP in 95% of cases is really easy to manage, and then we have 5%, like you suggest, who are really difficult. They fail steroids, they fail rituximab, they fail one TPA receptor agonist, and we have a number, you must also have a number of patients who seem to respond to nothing. So what can we suggest? Well, I mean, obviously you would revisit the diagnosis. Is it really ITP? If it's someone older, could it be myelodysplasia? Do you need to repeat the bone marrow, repeat the blood tests? Occasionally we pick up a lupus or something that we missed at the beginning, but now it's more obviously a secondary immune thrombocytopenia rather than primary. So assuming we've got the diagnosis right, and of course, for your audience of over 1,000 people listening, ITP is a diagnosis of exclusion. So by definition, there will be people we treat who really don't have ITP. They have something else that looks like ITP, but we cannot diagnose it because we have no tests for what they have. That's the reason some of them don't respond well. Anyway, so what do? Well, we can do nothing. We can observe them. If they're sensible and not bleeding, we can allow them to be home, but to contact us in an emergency. If things are stable, that may be the most pragmatic way and one way of avoiding destroying their quality of life. If you have a drug trial running in your institution, you can offer them the opportunity to take part in a trial. But of course, during a pandemic, running trials is very difficult, if not impossible, we have found. You can combine therapies that you may have used before. You could give them 2 TPOs. L-trombopag plus romiplostim has been used, and occasionally it works. You could combine, as we've seen in the ASH abstract, a TPO plus mycophenolate. either one alone may not give you a great result, but if you synergize them and give them together, they work better. For example, if you have cancer, if you have AML, you don't just give one drug. You attack it from different angles, different parts of the cell cycle. So you would never expect a great result for acute myeloid leukemia with a single agent. So why do we expect great results in ITP with a single agent? So why not use a TPO-mimetic plus some immune suppression or some combination? The McMaster regimen, Donnie Arnold published the McMaster regimen, azathioprine plus cyclosporin plus mycophenolate. It's a horrible combination, but it works for some people. Or give them high-dose cyclophosphamide, IV, like Terry Gersheimer published back in 1998 or thereabouts. So there are lots of things you can play with, and sometimes you hit on the right magical treatment, but it's hit and miss, trial and error. It's very hard. It's a very difficult group. Sorry, that's my best answer. Sorry.
Okay, there's a question for Dr. Drew. This is the case of a patient. Okay, the question is very concrete. A patient whose platelet count is between 60 and 70,000 and with abundant menstrual bleeding. So the question is, shall we wait or shall we give treatment as primary ITP? So this is a discussion for differential diagnosis. But considering your expertise, Dr. Provan, and since this is a very specific question, it is for you.
Okay, well, thank you. Again, you're picking on me. But anyway, the platelet count is 60,000 to 70,000, correct? 60 to 70. Okay. Okay, well, heavy menstrual bleeding is common in women worldwide anyway, I mean, without ITP. So, make sure with a platelet count of 60,000, that's a very reasonable platelet count. It's slightly surprising someone has menorrhagia with such a good count. So I would first of all wonder, is there a gynecological cause? And I would refer the patient to my gynecology colleague just to make sure there's nothing we're missing. I mean, that something non-hematological. She could have fibroids. It may be hormonal or some gynecological cause. Okay, so if there is no gynecological reason whatsoever, and she still has really heavy periods, despite having an adequate platelet count, then we would wonder, has she got bleeding anywhere else? Could this be a platelet function defect in addition? Because sometimes if there's an antibody in ITP, and often there is, against a platelet glycoprotein, it may hit an important part of a molecule on the platelet which interferes with function. Usually they do not interfere with function, but sometimes they do. So we would rule out a platelet function defect by doing laboratory assays for platelet function defects. So if that is normal and she does not have a gynecological cause, that is unusual with a platelet count so high. But then we come down to quality of life. This is probably affecting her quality of life. And just like fatigue with ITP, sometimes you have to treat the symptoms. Don't worry about the count. Let's treat the symptoms. Her main symptoms are bleeding. Can we stop the bleeding? You could give treatment. Of course, this kind of patient, I don't know if she presumably would have had a first-line treatment at some point with steroids. So we would probably use a TPO receptor agonist as a trial to see what effect it has. The chances are the platelet count will rise more than, so go up to 80, 90, 100,000, and her bleeding should stop. And if the bleeding stops, then I think treatment is the right thing to do. Whatever you choose, it doesn't have to be a TPO, it could be something else. You could give rituximab if you want, or give mycophenolate if you want. Whatever you do, if it raises a count and stops the bleeding, then continue the treatment. But I'd want to make sure there's nothing non-hematological. I want to make sure it's real before I start going in with a therapy, which is appropriate, really, if that makes sense.
Well, before giving the floor to Dr. Gregorio, I'd like to emphasize, since we have many attendees, a patient above 60 or 70,000 platelets, as Dr. Drew says, they have localized bleeding. We have to look into other causes for this bleeding or differential diagnosis, because this differential diagnosis, over the years, we've seen differential diagnosis that are not ITP. Sometimes they are giant platelet syndromes, gray platelets, etc. So it's very important to rule out acquired causes. And if a patient has thrombocytopenia, we have to look into other causes of thrombocytopenia. Maybe they are bleeding because of thrombocytopenia or coagulation disorders. So this could lead us to really diagnose primary ITP. Before giving the floor to Dr. Gregorio, apart from what you want to say, there's a question. What's the role of certain agents with primary ITP? I think this is linked to the previous question. I wanted to say there are differential diagnoses. Even the most common one is type 2, but we also have type 2, but we have to make sure that it is ITP. And I wanted to talk about this agent you mentioned that can be used if we ruled out gynecological causes and there's still ITP. We should consider the use of this acid to decrease those abundant bleedings during menstruation, and also spare us the deleterious effect of therapies, steroids or immunosuppressant. Maybe try with this acid. Yes, this acid is quite useful for primary ITP patients, especially with patients with abundant bleeding. So we can use tranexamic acid. I'm sorry, I don't get the name of the acid. 2 tablets of 250, and then we discontinue it. We have to let the fibrinolysis system to work properly. And in those patients with bleeding that is compromising the function or an organ, like the brain, eyes, lungs, yes, it is useful in patients with bleeding events, and it can be used in emergency cases. If there's no bleeding, it shouldn't be used. And in this case, this patient, we should consider other causes or other systemic therapy with immunosuppressant. In pediatrics, Dr. Lozano, a colleague from Guadalajara, asked, what are the treatments, the most aggressive treatments in a patient with thrombocytopenia with no response? What would be the suggestion? Aggressive treatment, waiting for an answer, well, for a response, sorry. Well, maybe they're talking about a combination of several drugs. That's the question. They don't say if it's pre or post splenectomy. What could be the management of this kind of patients? Well, to start with, if there's no response in pediatric patients, we have to have this diagnosis by exclusion. We have to redirect the diagnosis, and even before splenectomy, we have to conduct tests of bone marrow, infectious diseases, autoimmune diseases, to make sure that this is ITP. If they do not respond, we can use thrombopoietin, and even we can use periodical immunoglobulin every 3 days, and also the combination of IgG and steroids like dexamethasone orally. The anti-D periodically is used as a second-line treatment, and if they do not respond, we have ARTPAO. There are some schemes that combine steroids, so we have these options available. And at the end, we will leave splenectomy. Personally, there are some patients that are positive for cytomegalovirus, and some patients have responded after they do not respond to anything, but they are positive for these viruses. So we have to see that this is the cause of the lack of response. So just as Dr. Drew said and Dr. Gregorio said, we have to make this exclusion diagnosis. Just to wrap up, there's a question which is very valid because it might confound all of us. What about a patient with an established diagnosis of ITP, or at least this is what we think, and they report in the blood count platelet aggregates? What would you do in that case? Okay, Gregorio, you are examining a patient and they report platelet aggregates. What do you think? So specifically, what would you do in this case? Could you suggest using heparin or a blood film? Okay, so tell us what you can do if you decide to make a film. First, if it's a patient with a diagnosis and is bleeding, of course, the platelets will be low due to the antibodies. If it's a patient who is not bleeding and has a diagnosis of ITP with no bleeding, it was not confirmed. Yes, apart from the film, because the aggregate will appear in the film, you can make a blood count with heparin and citrate. Consider the possibility of a pseudo thrombocytopenia. That's important. He bled or not, and see that the antibodies are also in the platelets and can be aggregated in the case of ITP. So I think it's the clinical manifestations and the blood count and the blood film with anticoagulants. Okay, perfect. Well, there are many questions, and I think all the questions are important. Well, given that Dr. Drew is 6 hours ahead from us, we're going to stop here. I'm very sorry for not being able to answer all of them. There are many interesting questions. And we thank you. We thank all the speakers and tell you that we are closing with almost 1,400 people attending the session from all around the world, Mexico, Latin America, Mexico. We thank you for your attention during this session. We are going to continue with the sessions. This is a motivation for us due to the expectation. We thank you for your attention, for following us. So we have 1,350 people plus 70 people online. So this has been one of the sessions with the highest number of people attending. I thank you very much, Dr. Oscar. I give you the floor to close this session. Thank you, Carlos. Once again, Dr. Drew, Dr. Lozano, Dr. Campos, I thank you. You saw the amount of people who attended this session to listen to you, because this is a very interesting topic. I thank you for your time again. I'd like to thank especially Ms. De La Teja, who works with us, Montserrat De La Teja and Jimena Castro. They are very important for us in the administrative and academic departments of our association. And as Dr. Martinez said, I thank all the groups who have joined us, our members, Latin America, and of course, I'd like to thank Novartis for your support, and also this company that helped us with the streaming, which is JC Innovation. Thank you very much and have a good night. Thank you.